Hello all, my name is Aman Khurana. As you guys know me, I'm the vascular medicine guy for the group, and my talk been given to me is chronic venous insufficiency. So I'm going to talk about chronic venous insufficiency as whole. What does venous insufficiency mean? Veins, they're deep, they're superficial. So I'm going to talk about differences between venous insufficiency from deep veins, what you could do, and what to do with venous insufficiency from superficial veins. And a lot of time venous insufficiency could be non-venous. It's a complicated word that I'm saying, but what it means is that veins are failing not because they have deep vein problems or superficial vein problems. They have problems because patients don't use their calf pump. This is how veins don't have a heart. Calf pump is the heart of the veins. So patients who are immobile, who don't walk well, who have Parkinson's, people who walk more like this without using their calf pump like they walk, they get venous insufficiency just because of the fact they have been sitting and not working their calf pump. So you'll frequently see me telling all the patients to keep their leg up and do calf pump, because that's a very, very common problem now. People with pulmonary hypertension, people with fluid overload, people with congestive heart failure, they just have extra fluid. Veins actually carry 70% of all fluid slash vascular supply in the body. Arteries have a way smaller carrying capacity than veins are, and veins actually tend to accommodate a lot more. When extra fluid happens, that's really in the venous system. And I have started thinking of veins as a veno-lymphatic system together, because they are complementary to each other. And a lot of time when veins starts failing, you start getting lymphedema also, because the lymphatic after some time stops failing also. The lymphatic supply gets overburdened when veins don't work, and at some point you'll see lymphedema happening, and you'll see in my notes a lot, I'll call phlebo-lymphedema. So it's not primary lymphedema that happens in younger people, it's because of extra fluid overload. Patients tend to get lymphedema. So you see a lot of times I'll use the word phlebo-lymphedema. What it means is, phlebo means vein is the primary etiology that led to lymphedema. Alright? Alright, no financial disclosures. If you feel like, you can refer the patient to vascular clinic or to St. John's Hospital for the wound center. Another thing, I'll very emphasize something. If you have a wound on a patient and that wound comes from here to somewhere here to here, if you close your eyes and say that wound is venous, you're 90% right. 90% right. And when I say venous, I'm including fluid overload. I'm sure you guys have all seen blisters. They're not supposedly venous because they're not venous ulcers, but why are they happening? Because there's extra fluid in the venous system that goes into interstitium, and then these patients get extra blister fluids basically, which technically they're not venous ulcers, but I count them as part of venous disease because they're due to the fact their venous system overloaded. So chronic venous insufficiency, deep and superficial again. I'm going to talk about superficial and separately a little bit. So prevalence of varicose veins, I'll go over prevalence data also. Venous disease, as you'll see, is more than 20-30% in women, or men also actually. Way more common than PAD actually. 2 to 3 times more common than PAD. 20 million people have advanced chronic venous disease, and then as you heard from people, this is probably going to get worse as the population ages. So venous insufficiency, the next part is post-thrombotic syndrome. This is a sequela of venous disease. Post-thrombotic syndrome is because patients who get a DVT, if you look at these, veins have valves. Blood clots happen right behind the vein valves. So what happens is these vein valves that are supposed to close, the clots happen and they become incompetent. They don't close very well. So now after a DVT, they get incompetent. So the blood goes up, the valves don't close. So when we walk, blood goes from this segment to this segment, this segment, and this goes up. But when you get deep venous DVT, the valves stop closing, so blood goes up, keeps coming down. So what you get is post-thrombotic syndrome, either from a clot that's obstructing it And most commonly due to venous valvular insufficiency, the deep vein valves also get leaky. So 20 to 60% of patients with DVT develop post-thrombotic syndrome, depending on where the clot was. If you have an iliofemoral clot, the incidence is more than 50%. Femoral, popliteal, it goes to 40-50%, calf also, but mostly the more proximal the clot, more recurrent DVT, you get more and more post-thrombotic syndrome. 5 to 10% develop severe post-thrombotic syndrome. This is the most common complication of DVT. People think PE, this, that. The most common complication of DVT is post-thrombotic syndrome, is deep valvular insufficiency. And there's a significant morbidity, mortality complication to these patients. A lot of cost involved. Patient miss work days and venous ulcers and all. But that happens in only 5 to 10% patients. But imagine people, everybody who has DVTs or recurrent DVTs, 5% of those patients get venous ulcers. That's the point, because of deep venous reflux. Now, prevalence of venous disease, this is a study from 20 years ago. How many people, if you look here, how many people had is there a pointer here?
Maybe on this black. In there, possibly.
Okay. So how many people, this is in England, in Edinburgh, how many people had varices, truncal varices? You know, it's frequently felt women have more varicosities than men has. But actually, if you tease up more, that's not true. Men have a lot of varicosities also. They have venous disease. They're not as symptomatic from the point of view of cosmetics, and also they tend to report it less. But 33%, 26%, if you go venous insufficiency, as common as women and actually more. So it's almost a wrong thing to think that only women have it. So this is from Dr. McLafferty, used to be here many years ago. This is from Journal of Vascular Surgery in 2009, I think. 2,200 patients underwent screening. I just want to see how many patients had venous disease. 30% had symptoms of venous disease, and I'll go through this classification later on. C1 is small veins, C2 is varicose veins. Almost 22-23% have varicose veins. This is on general screening. And then you get C3, C4, and you'll see. So basically, you're easily talking about C0. Again, this patient don't have varicosities, but they have symptoms. So this becomes a little subjective. But even if you take C0 out, the incidence here is quite significant. So there's prevalence of venous disease is a lot, way more than peripheral artery disease. And as cardiology, vascular guys, we tend to focus on PAD, appropriately so, because that's a significant problem. But you'll find out more and more, you'll see problems related to venous disease in future. And I think we already see, in wound center, I can tell you, I see way more venous wounds than arterial wounds. Way more, almost a ratio of 5 to 6 to 1. Again, the same in a vein consult program, C1, C2, C3, 22%, 15%, you get the point. Very common problem. So prevalence is there. What is the pathophysiology on venous disease? The biggest problem for venous disease is chronic venous insufficiency, venous hypertension. You have high pressure in the veins. And how do you get high pressure in the veins? Either due to the fact that you have iliac obstruction or some DVT that did not completely open up. So you get persistent and residual venous obstruction, or actually way more common than this is valvular reflux, whether you have deep venous reflux or superficial venous reflux. You get a lot of reflux. So it's the same thing. You get reflux because the vein now starts leaking in the deep system, or you have reflux. And if you look at this, these are the valves that close. Valves start leaking, vein starts getting bigger because they have more fluid than usual, and then they start getting varicose. So that is typically what a lot of superficial venous disease looks like. And then this is for deep venous reflux. Superficial venous reflux, deep venous reflux. And this is essentially the same schematic. You have normal blood flow here, but when you have venous insufficiency, the valves are incompetent. They are not closing anymore, because when we walk, blood pushes up, these valves close, they don't come down from here because the valves close. Here, when we walk, blood goes up because it has to, and then it keeps coming down because the valves have gone down in superficial, deep. And then this is again, you pump the blood up, and in an incompetent keeps coming back. This is a patient how after we exercise, a normal person, I do this. See what I'm doing? I'm doing calf pumping muscle. I do it for 15-20 seconds. I can bring my pressure from 75, 80, 100 down to 20, 25. And then it takes me 30-40 seconds for my veins to refill back again. This is a normal patient. But what happens in somebody who has venous reflux or superficial or deep either reflux or obstruction? First, they are not able to get down to 25 even after they're done, because it doesn't empty anymore completely. And see how quickly it filled up? The venous refill time is very fast. That essentially means that you have venous. So your problem first, you could not come down here, and second, see how quickly it went down. And here it takes 30 seconds to come. And I'll have some more pictures basically showing what happens here. This is a normal patient. You and me, we walk, we get our pressure down from 90 to 25, and it takes 30 seconds to get it up. Somebody with superficial venous reflux gets from 100 here, and this third patient, this is the patient who has significant post-traumatic syndrome with iliac obstruction or issues. They cannot even get it down. These are the patients that come with venous claudication. What they say is, my legs are just heavy and I can't walk. This is different from PAD. They'll tell you that when you put your leg up, it feels better, it gets less swollen, it feels less heavy. Because what happens is when they put their leg up, the gravity gets the blood back to the heart. When the leg is down, the gravity is not helping. So when they put their legs up, this is a big difference. PAD, severe PAD patient, when they put their leg up, actually their gravity works against them. So severe PAD patient, you'll hear at night, I have to get up and put my legs, they get up because of pain. So I ask them, what happens? How does the pain get better? I get up and walk. Or I sit by the side of the bed. So what happens is, they put their legs in a dependent position. So a little bit of extra blood that goes down helps them, and they're not ischemic, and they go back to sleep. And they get up due to rest pain again, and they get up and walk around or put your legs down. As compared to venous disease, they feel better when they put their leg up, because that's what drains the extra venous system back to the heart. This is another presentation as to how it happens. When we're laying flat, our venous system is the same pressure as the RA, which is 5 mm mercury. And then we start rising, and then we start standing, and it goes to 100, 75, 80, 100. And we start walking, a normal person goes all the way down, and it goes up again. Few steps. What happens in somebody who has superficial peripheral vein dysfunction, it comes down. In somebody who had proximal venous obstruction, he won't even come down too much. Somebody who has deep and venous reflux, he'll stay there, superficial will probably go down a little more. So the more the problems, the worse off you get. So this is the pathophysiology, and that's what happens why the venous disease is a problem. Venous hypertension is the problem. Whether that happens due to obstruction or due to happen to venous reflux, either in the deep system or in the superficial system. What are the symptoms of venous disease? These are the typical symptoms of venous disease: pain, heaviness, tiredness, fatigue. They'll itch and burn where the varicosities are. You start getting over time. You start getting skin changes in your legs, and I'll have a few pictures to show you. So these are the symptoms again: pain, heaviness, cramping, fatigue. These are all patients that I hear every day. Venous claudication is a pretty significant pain that I don't hear it every day. But that's a pretty significant. I had a patient that I recently referred for bypass who complained of this venous bypass because he complained of this problem. But then you start getting edema, telangiectasia is very small vein, then you get reticular veins. I'll show you how reticular veins look like. Then varicose veins, hyperpigmentation, eczema, pain during calf compression, and I'll show you what lipodermatous sclerosis look like. Atrophic blanches, you get these whitish lesions. This is after a wound has healed, and it doesn't look like normal skin, it looks like whitish skin. That's called atrophic blanch. And open or healed ulcer is the most active one. So remember I talked about the venous classification of the veins. So the venous classification clinically goes from C0 to C6. C0 patients have nothing on the legs that you can see that suggests a vein disease. But they have symptoms of pain, heaviness, tiredness, fatigue, swelling even maybe, pruritus. So, but they have C0 symptom-wise, but they have but they have nothing on the legs that can show. And then you can start seeing telangiectasias, the spider veins, or you can little bigger called reticular veins. Reticular veins are less than 3 millimeter. Once you start getting more than 3 millimeter, you start seeing varicose veins. That's C2. This is where minimum where you start doing something for the patients. A lot of my patients actually belong to this category that I do procedures on. I do C2 also, but a lot of my patients come from wound center and there's advanced vein disease. And I'm sure you see it every day, you guys see it every day. So C3 is edema. C4 you start seeing some skin changes. And C4 has been divided into C4A and C4B now. It got divided 15 years ago. Basically in C4A you get some venous stasis changes, and C4B you start getting atrophic blanch, or you start getting advanced venous eczema and lipodermatosclerosis, which I'll show you what it is. C5 is a healed ulcer and C6 is an active ulcer. Typically wounds in venous disease will come in this malleolar area, the gator area. Where is the highest pressure in the leg, in the veins? Right where the lowest point of the body. That's why you typically get venous ulcers right here. That's the lowest part of the hydrostatic pressure is going to be highest at this point, not at this point, not at this point. That's why you get the highest venous pressure here. You can see this is called ankle flare, or the other word, a fancy word. It is a clinical fancy word. You'll see sometimes I'll write it down, but this is again a lot of reticular veins at the ankle. Large varicose veins. If you see carefully here, these are the spider / telangiectasia. These are more spider veins. Then you start getting edema, hyperpigmentation in the legs here. Hyperpigmentation in the legs, and actually if you see this area, this is the old healed ulcer. You see this whitish, so this is what atrophic blanch becomes. And if you feel a lot of these wounds, these areas are like hard. So this is that hardness in the leg sometimes, hardness in the leg right here is actually localized lipodermatosclerosis. And I'll show you the classic lipodermatosclerosis, but a lot of that is very hard skin. And some patients have come to me with just hardness of the skin, have been to 5-6 doctors, and it's just hard area here. And this is just localized lipodermatosclerosis. An active ulcer, again a healed ulcer you can see, and this is atrophic blanch here. Healed venous ulcer is one of my patients. You can see all this area. This is completely new wound that's healed up here. This patient has a very large ulcer and ultimately healed over time. Active ulcer here, this is typical for vein disease. Typical for vein disease is right at the gator area. You can see these smaller veins here. Again, down right here, gator area, you see these shallow edges, irregular borders. There's no necrosis, a lot of slough on the wound. Typical venous ulcer. Typical venous ulcer here. Again, irregular, this is the area, and a lot of slough in the wound there. And if you get a venous ulcer, and I'll come to specific treatment for venous disease and venous ulcers, what do? You have to do compression. And the answer is compression. And that's why I brought you these things. Whether you do compression from simple compression stocking, 20, 30 compression stocking, Jobs, Juzo, Medi, I don't care, just good 20, 30 stocking. Or sometimes you get lymphedema, you get phlebo lymphedema, then I insist on a particular lymphedema wraps. Or some patients who just don't have the physical strength to put the socks on. I'll let zippered stockings, but that's not what I prefer at all. But something's better than nothing. Then circades or ferro wrap or ready wrap, these just go around, and these are just, you patient just tight it and put it back here. Again, these are not my favorite because patient could just have them on and not be tight, but good patient will tight it. The other part with these is they are really supposed to be worn with the foot wrap of it. So there's a sock that comes that goes up to here. If you just have from here to here, that's not going to help the biggest part that's right here. So you have to have a socklet around veins. But a lot of patients, the problem is, essentially the problem is compliance. And that is why I see in wound center, I see venous patients all the time back and back and back. They just back all the time. That's because of this, compliance. So the answer is compression, have them leg elevate, and calf pump exercise. I actually do calf pump exercise a lot. I ask them to every so and then during the day, every couple of hours, put the leg up for 5 minutes and do calf compression. And actually I ask them to do toes compression, because that's where the veins are starting. Toes compression, and then calf compression, and try to move it. If there's a deep venous problem, you intervene.
Yes, I'm doing toes.
Me too.
Yeah. Right now I'm wiggling my toes, just so you know.
So if there's a deep venous obstruction, you have to open the obstruction, because that's not going to change. And ablation, if there's a superficial venous incontinence, ablation or foam square therapy or staph phlebectomies, which we all offer here. So when we talk about 20-30 stockings, or even 30 to 40 stockings, sometimes I do for phlebar lymphedema and lymphedema patients. I sometimes go 30-40 stockings. But I always start patients at 20-30 stockings. People don't like stockings to start with, and if you start them with 30-40 stockings, they're really tight, they're probably going to soar off and never going to use it. So always start people on 20-30 stockings. I sometimes go to 15-20 stockings. Patients are older, they just don't have the strength or arthritis that they can't. Sock donor really helps get the leg up. You put it on this, and then you can essentially put your leg into it. And it's very easy with this, and this is not expensive at all. Sock donor is really a great tool.
Do they have larger ones?
They have larger one also. They have larger one also, but this is a really good tool, and I very frequently prescribe it for people who have arthritis-related problems. So I do use 15-20 stockings, generally only for people who are older, who just don't have the physical strength or arthritis, or there's a lot of problems in patients who they're bigger, they cannot even reach their toes anymore to put the socks on. So this gets very helpful. They can put it on this, and then they can stand an easier leg into it. It gets, if you get used to it, this is a lot easier to put it on. So in a 20-30 stocking, what do you 20-30 stocking mean? 20-30 stocking means that right at this point you have pressure of 30 millimeter mercury, and that decreases to a 15-20 millimeter pressure out here. But it's 30 right here, and it's a graduated compression. And the same thing with all garments actually. The highest problem point is the most lower point, and that's where you have the highest pressure. Zipper stocking, not my favorite, but I'll let it slide. You'll be surprised how many patients come and show me their zipper stocking. I tell them that I don't like it, but then the option becomes they don't even wear anything. Not that I like it, but again, somebody who has had venous wounds, I really don't prefer. This is leg elevation. You can go to Walmart, Target. You can buy these. You can buy these and actually get good result. And when I recommend compression stockings, I recommend compression stockings from first thing in the morning to last thing at night. You really want to insist on this, because if the patient wakes up, goes bathroom, shower, toothbrush, coffee, iPad, iPhone, newspaper, whatever they do, 2-3 hours have gone by, and by that time the leg's swollen. So they really should be putting compression stockings first thing in the morning if these are serious venous disease patients. Not just varicose veins, but if they have venous ulcers, they really should be doing it from first thing in the morning. I actually tell patients to shower at night, put moisturizing lotion at night, and you wake up in the morning, so you wear your stockings from first thing in the morning to last thing at night. You shower at night. And then you wake up, so there's no shower, no bathroom, no nothing involved. And again, if patients complain that there's not enough, or especially women, if there's not enough fancy stockings, there's a lot of fancy stockings now. What I'm wearing is, patients really like it. There's beige color ones that are in design. I have a black and gray one. So there's a lot of stockings that people can wear now. There's the sheer dressings, the sheer stockings. I have one of these here. You can see this. It's actually, it can go along with some dresses even. This is, again, I have it here, Circades, Ferro Wrap, Ready Wrap. And if you see this one, this is right, it has a foot part also. The foot part is very important to wear, very important to wear. This is a multi-layer wrap, Pro 4, when we patients have wounds. What this one does is, here you can see this part, it has 4 layers of compression. Well, basically these patients are oozing, so first you want a lot of compression, but then you want something that will absorb their drainage also. We initially when I put it on, I change it every couple of days, every 3-4 days, and then once the venous drainage decreases, then we can go to once a week or so. But initially should be done regularly every 3 days. So if I put a Pro 4 on patient today first time, I'll have them come back in 2-3 days, because it'll probably soak through if I don't do anything, if I wait 7 days. Once the edema comes down, you'll see the difference. And this is a venous, again a Pro 4 going on. And what happens in Pro 4? You have a 4, if you put a Pro 4 right, you have a 40 millimeter pressure right at the ankle here, and that decreases to 50% of the top. But the whole concept, you get the point, it's a graduated compression with the highest pressure right here. I'll show you, like this is my patient. A lot of venous drainage here, venous wounds. See how big the leg is? Almost seems like this size. And you see this patient, as it gets better, you'll see this leg gets smaller. Now, wound is much smaller, but just notice the difference between from that point to this point, as compared to from here to here. And now when it heals, see the difference now? I tell patients all the time, I didn't do any magic. I just got the fluid out of your leg. I tend to teach patients as, think of skin as a garden. Your garden got too much water. It's not going to heal. So I got to squeeze water out of the garden. And once you get the water out, once you get the fluid out, wound heals. And how do you get, the compression is one way, diuretics is one way, leg elevation is one way, calf floor exercises. These are all things that get venous pressure down, to reduce venous hypertension. The key is reduce venous hypertension.
I have a question. So the white or like the really light pink,
Yeah,
that's the atrophic.
that is
blanch.
atrophic blanch, yeah.
And then what about what would you call the darker part around
These
it?
are venous stasis changes. These are advanced venous stasis changes.
Okay.
Some patients get very initial lightness, and you'll see some more picture. Initial darkness, that is early venous stasis. These are advanced venous stasis.
Okay.
But this is atrophic blanch from a heel, and actually as time goes by, this may start becoming more and more skin. I've had patients, I never promise patients, but I've had patients tell me that their darkness, this darkness has improved after ablations. I never promise it, but when they tell me that this happens, then I really know that I've really brought their venous hypertension down over a good amount of time. It doesn't happen 5 days after the procedure. It happens months, 2 years after the procedure, because it takes time for that process to reverse. In general, in medicine, we're taught you can't reverse what's happened. And that's true. That's why I never tell patients that. But whenever a patient tells me that their hyperpigmentation, their darkness, they will tell me, this darkness has improved, I know I've done something right. Because the darkness doesn't go down till you reduce venous hypertension. Because what is that darkness of the skin? That's hemosiderin depositation. And that's from extra blood there. So the hemosiderin deposition has gone down, and that's why the color has lightened up. Same thing here. If you see this, advanced venous stasis changes, venous ulcer, healed, Pro 4, healing. These patients have advanced venous stasis changes. I don't think I have early venous stasis where you just start noticing hyperpigmentation. Changing gears here. So this is venous ulcer. This is a patient I had from 10 years ago. The guy, young guy, 37-year-old, comes to me, he has suprapubic varicosities, right here, varicosities here. And he had a DVT 15 years ago. He was on trauma when he was in 2021, he had a DVT. And then And then what had happened, he had a DVT, and that DVT occluded his iliac system. DVT occluded his iliac system. So vein is coming up here, and this is occluded. So what happened? Collaterals are going here and bringing the blood. So those, if I take them out, I'm making major mistake. If I treat his varicosities, the problem of varicosities is that is the outflow, venous outflow of his leg, because his iliac vein is occluded. And what had happened? Most likely, what had happened was May-Turner syndrome. He had an extensive iliac DVT. What happens is the left common iliac artery compresses right common iliac vein, right here. This is a normal physiological finding in 25-30% of people. There's some degree of compression happens in a lot of people. But it becomes, that is why you'll notice that left leg DVT is always more common than right leg DVT. In general, left leg DVT is twice as common as right leg DVT. That's because of some degree of May-Turner syndrome. So what you have to do in a situation like this, like that other patient, you have to treat the venous obstruction. You get DVT because of this. And how do you find a DVT? Very simple. Actually, when we do compression, when we do venous compression at the groin, when you do compression, the veins have hardly any pressure. You've been able to compress them. And then when you compress it, the artery is going to go like this. The vein just compresses. Some vein that has a DVT is not going to compress. So as a venous duplex scan is, non-compressibility is the key. You have a non-compressible vein, that's DVT. And this is what happened in this patient. You see that? A collateral going this side. Left common iliac vein and IVC, compressible right common iliac artery. May-Turner syndrome. So this is all collateral supply going on this side. Once we open this should go down, and then you have an open system.
So he had a chronic DVT in his iliac.
That's right.
Okay.
From 15 years ago.
Right.
And I didn't show his legs. He had, I don't know if, no, I don't have it. He had venous disease, venous stasis changes already in the leg.
Just his left leg.
Just his left leg, because his DVT was on the left leg. He had iliac venous obstruction. Actually, if I do just a simple venous study, if I do vein evaluation here, he doesn't have any clot here. So, and I actually, because he has such good collaterals, I cannot make a difference between the two sides. So if somebody has a new clot here, and I'm imaging this, I can actually find out because a venous system in the vein, when we take deep breath, the vein goes like this. A vein that has a clot up there between heart and this part I'm imaging, it will have like this. It will not come down to baseline, because even if you take a deep breath, the connection between the right atrium and that particular part of the vein, there's a blockage in between. So it won't have the respirophasic. And at the same time, you'll see some of the lower extremity veins. I'll comment that pulsatile waveform noted. And what you'll need in pulsatile waveform is the same level here, and you'll see vein going like this. That means the extra fluid, right-sided fluid overload. So they're pulsatile because the right atrium has a very high pressure. The right atrium has a very high pressure, so they're very pulsatile. Even the veins in the lower extremities. Veins in the lower extremities are not supposed to be pulsatile because they're far away from the vein. They're supposed to be phasic. With respiration, they're phasic. But the upper extremity veins, because they're very close to the heart, normally they are pulsatile. You see, pulsatility in upper extremity veins is normal because they're very close to the heart. So, role of arterial disease in venous, arterial testing in venous disease. Normally, you see those wounds, that is a venous wound. That is a venous wound 95% of the time. You can just take a look at it. Now, should you rule out arterial disease? You should rule out arterial disease. Why? Because a lot of these patients are older, they have concomitant arterial disease. Because you don't want to be compressing a severe PAD. So imagine somebody has a PAD, have ABI 0.4. Now, 0.4, 0.5, 0.6, anybody who has ABI low or whatever the ABI is, always take ABI with a little grain of salt on this older patient that we're seeing, because these are older patients who had non-compressible vessels, some kind of mesial sclerosis. So their normal ABI might be 0.6, but it looks like 0.8 because the vessels are not very compressible because they have diabetes, kidney disease, CKD, renal failure and all that. So always try to get toe pressures. That's why in our ABI, we always get toe pressures also. What is the toe pressure? What is the TBI? If the TBI is, normal TBI is 0.7, toe pressure. Normal toe pressure is 100. If your toe pressure is less than 50, 60, things are not right here. If toe pressure is less than 30, the arterial wound won't heal. Not venous disease, but arterial wound won't heal. So pay attention to TBI, toe pressures. So ABI is a good, but always pay attention to toe pressures also. And pay attention to the fact if you write pulse volume recording, we call it normal looking, and then it's pretty good. Okay, so the reason you want to do arterial testing in venous disease is not because you want to fix the arteries. Yes, you want to fix the arteries if you cannot compress the patient. The only time I refer arterial intervention in a venous disease is when I have an ABI of 0.5, 0.6, because I cannot put multi-layer wraps on these patients. Because imagine somebody has an ABI of 0.4 and I put a multi-layer wrap, Pro 4, and they already are not getting a lot of flow down to their toes, and I put a multi-layer wrap, and now their toes are not going to get anything. And you may see a patient 7 days later and he has gangrene in his toes now. Last thing you want to do. So that is why in the wound center, I always have my CV Doppler where even if I'm putting, I don't have an ABI, but I'll hear the pulses. I can hear triphasic, biphasic, monophasic waveform. Triphasic, you will hear, you'll hear it. And the monophasic, you hear, you'll hear, when you hear then you know there's obstruction on the top. I will not put multi-layer wrap on that patient. I'll put short bandages or something and then say, let's get ABI and we'll see the patient back. And I tend to get arterial duplexes also, because I said ABI is one part, arterial duplex is also helpful as well. But ABI is very important, and this is an ABI. Another thing with ABI is ABI overestimates your flow, and I'll show you how. You take arm pressure out of the tube. Whichever is higher, that's your pressure for the arm. You come to DP and PT, whichever is higher, you take that. You throw the lower one out. So if this patient has dorsalis pedis pressure of 20 and PT of 100, my ABI 100, 100 and 20, my ABI is going to be 1. But dorsalis pedis was 20. So I overestimated arterial disease actually. But don't forget that this DP, dorsalis pedis, was only 20 or 30 or 40, whatever. So I overestimated, but what I'm doing is I decreased my sensitivity, but I increased my specificity. Same thing, so higher the pressure goes, higher the pressure, 100, 150 let's say. If it's 150 here, 100. If I had taken DP, it would have been 0.66. If I have taken PT, it's 1, 150, 150, it's 1. So same thing, higher. So I actually, ABI in some ways is overestimating as compared to the other artery, because I take the higher of the two.
So do you get ABIs on every patient or just patients that don't have normal pulses?
If patient comes to wound center, I try to get ABIs on everyone, because I don't want to be blamed down the road.
So
something happens.
If I'm seeing a patient in clinic and they have like venous stasis changes in their legs and they just have lower extremity edema, but they have normal pulses.
That's fine. You can put compression stockings.
Okay.
You can. In fact, I've had healed patients. I have healed patients with ABI 0.45 venous ulcers. How? I saw the patient in Litchfield. Patient was from Staunton, a complicated patient. The guy was struggling at Staunton Wound Center for a year. So I saw him and I said, I'll heal your wound, you'll have to come to Springfield. I get a lot of patients from Staunton, Litchfield, every week coming to me. I had one of our interventionists do SFA occlusion. He said, send to surgery. I sent to the surgeon. Surgeon said, this guy's not a good surgeon. I'm stuck with the patient here. I mean, I get him from Staunton and he has both wounds and both legs had venous ulcers, but ABI 0.4 and 0.5. He had extensive venous disease on one, so I did ablation on him. He healed quickly. The other one, the one that SFA occlusion we didn't fix, and surgeon said too much high risk. I had him on compression stockings with ABI of 0.45 or whatever. But I told him that if you have problems, and compression stockings are easier. If you don't feel right, take it off. But with a multi-layer wrap, they cannot take it off. So I debrided every week. It took me 3-4 months or maybe 6 months, but I healed that wound. I haven't seen him. It's fortunate actually. I don't know. Maybe he's not living, but I haven't. A lot of times my venous patients, once a patient, always a patient. They are always coming back. I've never seen that patient again. But it was a good patient. He complied with compression stockings. He would come every week. I'd debride him. And I didn't fix it. It was still ABI was 0.45 or something, but it was a venous wound.
Yeah.
I would have healed that wound a lot faster had I been able to revascularize him, because then I would have been able to put multi-layer compression. But I healed him. 0.45 or 0.5, I forgot how much.
Okay.
And this is how if you have trouble, I see a lot of patients. You can have trouble feeling their pulses, but you can hear the pulses a lot easy. You can hear the pulses a lot easy. If you hear, and how do you find it? Just like here, you put your Doppler here or here, and you keep squeezing here. You keep squeezing here. The venous, you'll hear venous flow going. If the venous flow you're hearing, that means the artery is right next by. Artery is right next by. So that's the same thing I do. If I put a probe here, then you'll hear when I do this, you'll hear vein going on. And if there's reflux, you'll hear. And then if I'm right at the vein, and then I just need to, with the pencil probe, it gets a little harder. It is much easier with the wider probe. With the pencil probe, it's a little harder. The pencil probe, you just work it a little bit around. You're hitting the vein, artery is right next by. Artery is right next by. All right, what is the safe level for compression? For multi-layer wraps, the answer is 0.7. And the reason is 0.7 is going back to this. I didn't spend much time, I should have. Normal ABI is 1 plus. That is normal ABI. 0.91 to 0.99 is borderline PAD. 0.4 to 0.9 is 0.41 to 0.9 is clearly PAD. 0.7 is where 0.7 or less is where moderate PAD starts. Mild to moderate is 0.7 to 0.9. So mild PAD you can compress, moderate probably you can compress. As I've told you, I have compressed, but I get careful. My reason for indication for interventions, for arterial intervention in venous disease, when ABI is moderately reduced. And obviously toe pressure becomes important. I look at toe pressure also.
So even if they don't have claudication with their...
Yes, because I could not compress them.
Right, so their venous disease will just get worse if you don't compress them, or their wounds won't
The
get
wounds
better.
won't heal. So I don't do a lot of arterial interventions for PAD, for claudication. I think they get done too much. That's my
Yeah.
opinion, and patients don't get better because they don't change their lifestyle.
Yeah.
Once you do an intervention, you should be walking every day. And I've seen over time they lose their benefit because, it's a sedentary lifestyle, the problem. So I don't refer a lot. It's not that I don't, but I don't refer a lot for arterial intervention. If I see an ABI of 0.6 and patient doesn't have a ton of claudication, 0.5, I'll see the patient. I'll just keep seeing the patient. If patient doesn't complain of claudication, you don't have to do anything.
Right.
And
Unless they have venous disease.
unless they have a venous wound that you cannot compress. Yes,
Okay.
then your case becomes stronger for doing an arterial intervention. One, you're doing arterial intervention. For claudication, when you do arterial intervention, that is just a lifestyle thing. Here, you're trying to do it for healing the wound. That these are two complete different things almost. One, you're just making a patient feel better with his better walking. Other, there's a venous wound he has, and generally you'll see these patients don't come to wound center because they had a wound open 3 days ago. They come after they have had it for 3 months, 3 years. I've seen patients years
Yeah.
had the wound, years.
And I'm sure the increased blood flow from intervening on their arterial disease is helpful too.
So actually, you bring up an interesting point. So when you open a chronic occlusion for an arterial disease, they actually get more flow. They get more edema in the legs. So every time you open an old occluded SFA, they get reactive edema in their legs.
Sure.
So your transiently your venous ulcer would actually make it worse because you just open an artery and there's more
Right.
more edema. The venous disease gets worse a little bit for transient time. But now you can compress the patient,
Right.
and you could. Now you can compress the patient. You can get the water out of the garden, grass will grow. So now I've touched about arterial disease. Let's talk about a little bit about superficial veins. There are superficial veins in the body. Great saphenous vein, which is this vein you guys all know from vein harvesting, GSV. Then you have small saphenous vein, which goes right here, small saphenous vein. There's anterior accessory saphenous vein. It comes right with GSV and then it goes right here. And there's posterior saphenous vein which comes off GSV and then it goes right here. And there's something that's called the intersaphenous vein, which is a small saph that comes and joins GSV. That's intersaphenous vein. Used to be called vein of Giacomini. So there's a bunch of saphenous veins. Vast majority of the time when I'm treating venous disease, it's GSV. It's GSV. So think about this, 70 to 80% of my ablations are GSV, 10-15% ablations are SSV, and another 10-15% may be anterior accessory. And I've seen some patients, a lot of patients, I just did one yesterday. He was a GSV, but vein here, and then kind of here, it kind of entered the vein as if it was a anterior accessory. It kind of changed course a little bit, and I see it very often actually. Must have had a clot or something in the GSV, or veins have a very varied anatomy. But it entered the common femoral vein like an anterior accessory would open. And how do I know that? GSV goes right here. Anterior accessory is right here. It is right on top of your femoral vein and femoral artery, SFA and femoral vein. So when I start scanning and I see this, and I go a little deeper on the ultrasound, I can see the vein and the artery right down. So I know I'm anterior accessory territory, even though I initially started in the GSV and it kind of goes in there. I've very frequently noticed that it enters common femoral vein more as anterior accessory. But it was the GSV to start. So these are the veins that you normally deal with, the superficial vein. Then you see a lot of varicosities, tributaries that come of this, and you'll see these here. When I'm seeing the patient for the first time and I see these varicosities, if you see varicosities coming off here, this area, you know GSV is the problem. I have the patient stand up and I'll feel their legs, because I see a vein here and I'm trying to see, because when they're sitting, they're all down, you can't see. When I stand them up, I kind of feel them. See, where are they coming? You can start feeling a little bit in the thigh. Where is it coming off? It's important for me to find out where it's coming off clinically, to not treat. So a lot of these veins are interconnected. So this vein might be coming off here and it might go and go here. And I'll find reflux here and here. But I want to treat the vein that's causing the main problem. Where is it coming off? I want to do minimum possible, because I want to see these veins down the road also. So I always treat one vein and I'll let the patient be. I will not treat it till there's a problem, and I'll see what happens to the patient, rather than do GSV and SSV, because on my initial testing that came the problem. So that is why I'm actually very careful about not doing perforators and all that stuff. If you took care of the superficial vein, perforator is the vein that connects deep in the superficial system. If you took care of the superficial vein, the perforator may just go away by itself. So if you look at here, this varicosity is clearly covering up GSV. Small spider reticular veins. This is reticular vein, and these are spider veins still in ectasia. The definition is important for us because insurance companies don't cover anything that's 2 mm. It has to be 3 to 4 mm to be called a varicose vein. I've done many over the phone calls, and it kind of just irritates me, and I said, I've written large varicose veins. I never write large varicose vein. If I'm writing large varicose veins, I mean I'm feeling pretty large varicose veins. I'm feeling 6, 7, 8 mm varicose veins. If I write ropey varicose veins, I'm feeling a centimeter plus varicose veins. But because I didn't document, they'll make me call. Like, I wrote large varicose veins, and but there's a lot of abuse happens in the world, and I can understand what they're doing for. Because I don't treat all these smaller ones. I mean, I actually just saw a patient yesterday, actually in the gym working out, a young guy. He started talking about his veins. maybe 25, 30, I don't know how old is he. I said, I would do nothing. And the fact of the matter is, this is a recurrent disease. I do something, something's going to come back. And I tell patients that honestly all the time. Say, if I do something, it's going to come back. I have a young female patient, she's a realtor in town here, a young gal who has a lot of these spider telangiectasia, but she has GSV reflux also. So she comes and gets liquid sclerotherapy with me, which is completely cosmetic. And I don't think my liquid sclerotherapy is very effective because she has reflux going in the GSV. So no matter how much I treat it, there's basic problem in the GSV. And she doesn't have varicosities, and I don't want to really treat, she's, I don't know, she's what, 25, 30 years of age, maybe. If I treat it now, first that vein is gone, second she's going to get something down the road. If she's bothered with smaller reticular, then something's going to come down the road. So I tend to treat, that is why my lot of patient population that I treat ends up being C4, C5. I'm in a good practice here, I don't need to, do a lot of C2s. Or I can, but patients who complain, I'll do it. It just, I tell patients, it's going to come back. That's the way nature of disease is. The recurrence rate after ligation used to be in 20+%. With ablation, it's lower, but it's still there. I've started seeing in my practice, patients I'd ablated 4 years ago have been having more recurrence. With recurrence, it's a lot easier. You just do injection, foam stereotherapy that can take care of it. But some patients have a lot of. I have a patient who have done, I don't know how many treatments I've done. I'm just myself tired of. I just saw him a few days ago. There's so many. I've seen patients who GSV, SSV, SSV, and now has varicosities again and again and again. Just.
So if they're compliant with like compression therapy, their recurrence rate is probably much less, right?
I don't know. I don't think so. But I always tell patients to wear compression stockings. I've had a lot of patients who had varicosities, symptomatic varicosities. I put them in compression, and I see them back, and they'll say, "I am good as long as I wear my compression." So I tell them, "So wear your compression." First, medically that is the right thing to do, because you should ablate somebody who has symptoms despite compression therapy. And second, this is what I do on my brother, my father, my sister. If you're fine with compression stocking, why not just continue with compression stocking? Unless until they have C4 disease and all, because now that train's left the station. So you want to treat that sooner than later. And I still have a lot of C4 disease patients who are doing fine with stockings. It just, a lot of these patients, I work at Prairie, we have a lot of older population. It's not just vein disease, it's pulmonary hypertension, it's sleep apnea, it's sleeping in a recliner, not keeping the leg up. I can't reverse everything.
Right.
EF is 25-30%. I can't reverse everything. If I take care of the veins, I just took care of one problem. There's 4 other problems there that giving venous hypertension. Calf pump failure, the guy walks like this. I can't change that. He has a sleep apnea, he's non-compliant with CPAP. I can't change that. The guy sleeps in a recliner. If you ask patients, you'll be surprised how many of your COPD heart failure patients sleep in a recliner, because they cannot lay flat. They get short of breath and second back. You'll be surprised how many of my patients that I see in my clinic cannot sleep in a bed, despite me telling them every visit. That is why you'll see in my consults, I'll very commonly write the word multifactorial, and I'll say from what and what. Multifactorial from venous insufficiency, from CKD, stage 3-4, from pulmonary hypertension, from COPD, CHF, sleeping in a recliner, using NSAIDs on a daily basis. Well, these are all problems that give fluid overload. Very frequently I don't treat veins because what am I going to do for this patient? Yes, I'll do a procedure. I can brag that I did a procedure, but I'm not sure I helped the patient a lot. Because I don't think it does. And so that is why if I see a lot of simple edema in the legs, and I'll see reflux in one leg, not in other, I don't do the because I'm not sure the GSV reflux is incidental, or because edema is in both legs there. What am I going to do with? I'm pretty sure a lot of the obesity patients. It's really just clinically there's very limited benefit I'm going to get from that. BMI is 48 or something. I'm not reducing. There's a lot more stuff going on with edema there than just venous insufficiency. And I'm talking venous insufficiency where there's only some veins and some edema. I'm not talking of C4, C5 disease. Again, as I said, arterial ulcerations, like I get aggressive with wounds. Same thing I get aggressive when venous ulceration there. Now this patient who has multiple comorbidities and all that stuff, but has a venous ulcer, yeah, I'll treat that. If there's a venous, because here I'm doing something more than making their legs better. Would it decrease it completely? No. Would COPD reverse over time or CHF get better? No. Would they start sleeping in a bed rather than recliner? No. But I at least took care of one problem. And I think it does help. Some people actually don't do these patients, like it's because it's not going to help, because there's a lot more. So I understand that. So this is an example of GSV reflux. You can see where it starts here. And this, I can tell you, is if you feel that skin, this I would call localized lipodermatosclerosis. It will be hard feel to that darkened part. It will be hard feel. And I want to show you what clearly lipodermatosclerosis look like. You see this leg? Use champagne bottle. A champagne bottle is this and then goes like this. An inverted champagne bottle is generalized lipodermatosclerosis. You see how the skinny and then poof. That's generalized lipodermatosclerosis. That's advanced 4B disease.
And that's what those socks are for?
So see this.
Yeah.
But these are patients with big calves. This is lymphedema sock.
Oh,
You should feel this sock. This is a very good sock. This is a typical lymphedema sock. It really lasts 6 months. A lot of other socks don't last 6 months. The best of the socks, sometimes if you wear them well, don't last 6 months. That's why I tell patients to change their socks every 6 months. I insist on having at least every 6 months, if not earlier. And even lymphedema, even though how much expensive they are, they should be changed every 6 months. I don't know how many times I've seen patients who I say, this is, I actually, what I had them do, I take the sock off and I'll put my hand into the sock. I'll take the sock off. What I do is I have them take their sock off and I'll take my hand in there, right above the ankle, I'll do this. Right above the ankle. And I have over time learned to guess, it's just my idea, how tight the sock is. And I know which one is a good sock and I'll tell them this is a useless sock. Some people got upset with me because I can ask, this is a useless, and I tell them, this is not a good sock.
Do they only get one pair for
You
insurance
can
a year?
pick 2 pairs. Usually Medicare won't pay unless it's an ulcer.
Oh,
It
okay.
makes 2-pair refill of 6.
Oh, okay.
That's when you would order.
Each insurance company is
Yeah.
different as far as what they'll cover, if they cover.
Yeah.
How many
A
they
lot of
cover.
insurance companies will cover socks when there's a wound.
Yeah.
So I'll give them socks right just before I heal the wound. So there's a wound that I almost could have healed it in the wound center. I will not heal it. I'll give a compression. Say, go get a compression
Yeah.
stocking.
Yeah.
I'll heal you Monday.
Yeah.
Right.
Because that
That's
way
crazy.
they get 2 socks.
Yeah.
Yeah.
Or just call us on Monday and say your wound is healed.
So even
Yeah.
if they have like blisters, do you call that wound or?
Yeah, that is technically a wound.
Okay.
Blister, you see a blister, you're supposed to pop the blister because that water is not going to let the wound heal. A blister is just extra fluid there.
Okay.
You're supposed to pop it. And you have to address the underlying problem there. The underlying problem is, why is there blister? Because there's right-sided heart failure. There's extra fluid in that leg. That's why you get blisters. I see a lot of patients with, and actually the blister patients heal very fast. They don't have advanced venous ulcer, they're just blisters. You put them in wraps, they heal very fast. And the problem with these patients are there's a lot of cardiorenal syndrome going on. So I get a little reluctant to start managing the diuretics. That's why you'll see a lot of time me calling you guys or the cardiologist saying, you manage diuretics. They're not easy patients. And these are difficult patients to manage. I know you guys are watching their weight every day or every couple of, you have call them parameters. So if I start messing around, adding metolazone, adding spironolactone, I should maybe, but I get reluctant because they're already being managed. A lot of them are referred to me by you guys. They're complicated enough for you guys, and now I add my 2 cents on top of it also.
You can add your 2 cents what you want.
No, but I most of them are already on Lasix.
Yeah.
So the choices for me are spironolactone, metolazone, and a lot of them already have advanced kidney disease too. So sometimes if you guys are not involved, or the cardiologist is not involved, or Nalamath is not involved, I'll call the nephrologist even. Say, is it, because you want to do it with their blessing. Because I don't know if they've had hyperkalemia before with spironolactones or what has all happened. Some of these patients have type 4. I have a patient that I just saw today has a known type 4 RTA. They're going to get hyperkalemic if I do some, I get a little aggressive with ACE inhibitors or something like that. All right, so that is the GSV. How do we find reflux? How do we find reflux in the patient? Again, this is a venous insufficiency testing going on, venous incomp testing, venous incompetency testing, venous reflux testing. What we do is, the first part is rule out DVT. So we make sure there's no blood clot in the deep venous system. And then we scan the patient, and we're at the we're at the GSV here. We're seeing, so exactly what I told you. I have the probe here, and this is the next thing that is down at the ankle, and we have this thing that the sonographer presses with his leg, and this thing compresses, a little bit air shoots up, and the vein, imagine I'm targeting the vein here, the blood goes up. If it doesn't come back, there is no reflux. Blood goes up, there's reflux. I can hear it in my simple ultrasound, this simple handheld Doppler. So blood goes up, like I was doing, remember I was saying it, and the same thing is happening. I have a probe here, blood goes up, you hear that, there's reflux. And that's what it is. You pressed it, blood goes up, and then it comes back on the opposite direction. And you can see it. This is all reflux. And you can hear it.
So is that when you squeeze their foot? Is that what you're doing?
No, but that's why we have this machine doing it.
Right.
Because for sonographer, I'm very particular. Sonographer is not easy. They're bent down and they're going to squeeze the leg. They might as well. They have something that they do this and that squeezes. That puts air gets pulled in the column. Basically, it's just squeeze almost happening.
But in clinic, that's what you're doing.
Yeah, in the clinic when I have it, but I am just doing it with the hand. I don't have the whole machine.
Right.
So this is again the GSV starts. GSV starts right here, goes all the way. You guys know GSV right well. This is anterior accessory. Remember I was telling you GSV goes like this. Anterior accessory goes here. And typically, I'll see, I actually, when I see patient, this one, you know the problem is anterior accessory here. You see where the location of the varicosity, the location of the varicosity is coming right here. It's not coming off here. So if I see this patient in the clinic, I already know the problem is anterior accessory. Because the veins are not coming off here, the veins are coming in this direction.
Mm-hmm.
This is a small saphenous. Small sap starts here, it goes up, traverses in the back. It's a very interesting vein in some ways. 50% of the time, it finishes in popliteal vein. Sometimes it finishes in the gastroc vein, and then in popliteal vein. And then sometimes it goes up and goes into femoral vein. And sometimes it goes up as a thigh extension, goes up and joins GSV. Remember I was telling you intersaphenous vein, the old vein of Giacomini. So it has a very varied presentation. Sometimes you go up all the way to GSV here, you go up and join the femoral vein here, or join popliteal vein here. Sometimes it goes up and join gastroc here, and gastroc joins into popliteal. When you ablate this vein, you got to be careful. I almost ablate from maximum from here to here. I do not want to go down because sural nerve is very close by. So ablation happens only from here to here. And I'll go up if there's a significant leakage going on the up also. But you don't want to be ablating down here. Even when we do GSP ablations, you normally do GSP ablation right here or here because then the saphenous nerves get too close. You don't want saphenous nerve injury. You don't want pseudo nerve injury with ablations. Any question up to now? All right. Okay, I think we're done, and this is your question part, if you want to answer that. Any questions? So I think we talked about superficial venous disease, deep venous disease. I did not talk about DVT-PE, the treatment and all. That's a completely separate topic. Anticoagulation is the key. And despite anticoagulation, you're not able to reverse thrombosis completely. What I mean to say is venous abnormalities in a duplex scan persist after a DVT.
Because of the damage?
So what happens is the clot completely doesn't resolve all the time. So, but we use the word DVT, chronic DVT. Really, we shouldn't use the word chronic DVT. We should call it chronic fibrosis or chronic junk in the vein wall. We don't have a good word to call it. That's why we call it chronic DVT. It's not a DVT anymore. What happens? This is a vein wall. That thing just kind of sticks to the vein, or there's a strand in between. But vein will not completely normal. It will compress. It will just compress it here. Acute vein is dilated. Vein is always a little bigger than artery. So this is the artery. This is the vein. And when it's DVT, it's clearly dilated. The chronic vein, the chronic DVT kind of becomes like this. It becomes scarred down. And you compress it, from here it will go down in this much. Or you'll see some white fibrotic strand in it. So the chronic DVT we call is not a good terminology. We should really call it chronic fibrotic changes in the vein.
Because it's not a blood clot anymore.
It is not a blood
scar
clot anymore.
tissue.
It is a scar tissue in the vein. You
Okay.
got it right. It is a scar tissue in the vein. But that residual scar tissue is actually a risk factor for future DVTs. So that is why when I have a patient with DVT, I will always, before I stop anticoagulation, I will establish a new baseline. Because now, let's say common frontal vein, then it compresses and I see some abnormality. Now this patient has a recurrent septum or acute or chronic DVT. It becomes very hard for me to distinguish acute or chronic DVT. But last time, let's say if I had a compression, the vein came down to maybe 2 to 3 millimeter, now comes back and that compression looks 7 millimeter. Okay, this is not right. Maybe there's an acute or chronic DVT. Now that common frontal vein had a prior DVT. How do I know this is acute, this is chronic? This is very hard to answer. Get a D-dimer. I mean, this is not easy answers for me to give sometimes. I mean, Denise and Janet knows. I struggle with it sometimes. This is new, acute, old. I'll scan them in 5-7 days. Even I don't know what's going on sometimes. I can't look inside. I'm making guess on sonographic appearance. The guesses from sonographic appearance are not good. They're not scientifically validated. Because at best they become guesses.
How often do you see like recurrent DVTs on patients who are on anticoagulation?
Very rarely.
Okay.
Very rarely. I'm glad you asked. Feel free asking any question, things I didn't cover. Very rarely. First thing I think, when patients are especially on the newer anticoagulant, first thing I ask them, how many doses do you miss? I recently saw a patient who was on who was on AFib for Eliquis, came to me with DVT, and I'm already kind of like, what am I gonna? So I went to the room and I said, this is a tough situation because I've already read what's, you take 10 minutes before you go in to figure out why you're going in.
Yeah.
So this is a tough situation. You gotta, I'm not sure what to do. And then she says, if you don't know what to do, I said, and then next line itself, I said, were you taking it? She said, no, I was not. Honestly saying, I was not taking it. I said, now I know exactly what to do.
Yeah.
So it's like you made my job, you made my
Yeah.
job as easy as can be. 3 minutes ago was very difficult.
Yeah.
Not that it was very difficult, it's like I would have to go. This failure anticoagulation is serious business. Why did patient anticoagulate? So I would get a complete thrombophilia testing. I'll recommend malignancy workup. Could there be some occult malignancy that caused failure of anticoagulation? I'll have to complete thrombophilia workup. People don't anticoagulate. Can they? Yes, they can. If you go into Xarelto, Eliquis, Rivaroxaban on these trials, you'll find out 3 to 4% can fail anticoagulation, but not commonly.
Are those people the ones that usually have like celiac disease.
So if there's a failure of anticoagulation, I will do complete thrombophilia work. I will why? I will actually, in those patients, I actually go back to, I put those patients on Coumadin. Okay, this way, if they're non-compliant, I'll find out.
Yeah.
This way, I can't even find out. Her word and is all what I have. His word is all I have.
Right.
Some patients are very upfront, and then she was very honest. She told me, even my son doesn't know, even my doctor doesn't know. But I didn't want to lie. It's like, thank God you told me, because I'll be ordering 20 tests now.
Right.
Because it is not an easy answer. So if I have a true failure of anticoagulation, I actually put them on Lovenox. The recommendation is to put them on Lovenox for a month and transition them to something else. Some people transition to a different newer anticoagulant. I don't do that. It's like, if that fails, it's going to fail too,
Right.
due to whatever reason. Not that Coumadin is not going to fail. Coumadin may fail too, but I'm following guidelines. The guidelines say go to Lovenox for a month and then go to Coumadin.
Okay.
And rule out malignancy, first important thing is rule out non-compliance.
Right.
And thrombophilia workup. That is the right indication for thrombophilia workup if patients thrombose despite anticoagulation.
So if a patient comes in, because I just recently saw somebody with a DVT-PE, and so I think Dr. Goswami usually he'll get, well, it was unprovoked too. So, she's on anticoagulation, but he always recommends the thrombophilia workup, regardless if it's unprovoked.
If it's a young patient,
Yeah,
less than
she's
50,
in her 50s.
the recommendation is less than 50 unprovoked DVT, you should do thrombophilia workup. More than 50 unprovoked, recommendations are not to do thrombophilia workup, so I don't do them.
I think she might have a family history of
Okay,
blood
then
clots too.
that's right. So in fact, if patient gets a provoked DVT from oral contraceptives, female patient, young
Yeah.
patient, I actually check their factor V iron for thrombin universe. Not that it makes a difference for her, it may make a difference for her daughter.
Ah, okay.
Because if she has factor V iron, and let's say she's spasmed, at least her daughter doesn't use it.
Right.
I just saw a patient who's 47, provoked secondary to oral contraceptives due to some ovarian cyst or something, and her daughter's in 20s. I said, I'll check yours, not now, because she was having insurance, like life insurance and all that. Then you don't want to get in, because this gets tricky. You have factor V iron labeled and life insurance is
Right.
expensive. So I said, maybe I'll check it next visit. But I told her what I'm trying to do. It's not that it makes a difference to you,
Yeah.
but it may
For
be
your
helpful
daughter.
for your daughter.
Interesting.
Factor V Leiden, that's a good point you have. Factor V Leiden, heterozygous, one gene out of the two. One gene out of the two is as common as 7% of Caucasian population. Prothrombin gene mutation, heterozygous, one after two, is as common as 2 to 3% of the population. So some of these things that come positive mean nothing. But if there's factor V Leiden, heterozygous, and oral contraceptives, your risk goes log. Factor V Leiden, heterozygous, and heterozygous prothrombin gene mutation, and oral contraceptives, boom. Or prothrombin gene mutation, heterozygous, oral contraceptives. It's just not. It's not 2 plus 2. It's not 4 plus 4. It's 4 times 4 times 4. I mean, the risk just goes up. So if somebody has provoked DVT, has factor V Leiden, heterozygous, that does not change my workup. They get 3 to 6 months and they're done. Provoked heterozygous. Provoked but heterozygous, not
Right.
homozygous.
Okay.
Homozygous is significant. Homozygous is significant.
So they would have lifelong anticoagulation.
With one clot, yeah, I would put them long term.
Okay.
If they're homozygous.
Okay.
Homozygous factor V. Heterozygous factor V is as I said, it's very common.
You just treat it just like any other.
That's right. I've had a lot of patients with heterozygous who had a provoked DVT, and I tell them to be careful, because the second risk factor will increase the risk factor a lot. So if they be very careful when they go for a long car ride, plane travel and all that stuff. So patients who get a blood clot with a long car ride, blood travel, I actually think of them as minor risk factors. They are risk factors, but I tell these patients that you will most likely get blood clot in future again. Because I don't tend to think, who doesn't sit in a car for 4 hours?
Right.
but a very small minority gets blood clot.
Mm-hmm.
And I think because they're getting it for some other reason, and this is just another factor. So I tell them, drink a lot of water, get out of the car every hour or two, walk around for 5 minutes. Same thing for the flight, wear compression stockings, hydrate yourself, get up, walk around. And hydration is very important. We don't realize how often we are transiently dehydrated. Transient dehydration is not uncommon. A simple UTI, a simple flu, a simple not feeling well, dehydration is very common. I mean, it's, sometimes even working, we don't realize we haven't had water for the whole day. And that's dehydration. All right, questions?
What were you talking about with the ABI of less than 0.7?
So I would
Treating venous ulcers?
I would recommend arterial intervention.
So you wouldn't do compression?
I would not do multilayer compression. I would not do multilayer compression because I don't want to see gangrene.
And so, I guess with multi-layer compression, that's what you use for the venous ulcers. You wouldn't be using compression socks because they have the venous ulcer and they kind of need more.
So yeah, the compression sock would not be you would not want an acute venous ulcer because that's going to just
Get saturated.
Right, that's
yeah.
right. Venous sock is for long-term venous disease. For venous ulcer, you want multi-layer wrap
Okay.
because there's a lot of drainage in venous ulcers. But compression stocking, can they work? They can work. I've had patients with compression stockings, but I'll go with 15-20 compression stockings, 10-15 compression stockings,
With the arterial
and then work my way up if I need to.
Okay.
But you want to be careful. And as I said, 0.7 ABI is maybe not true point. Maybe it's 0.5 really, and it's it has diabetes and it's non-compressibility in the vessels, and even then it's 0.7. And God knows what the true ABI is.
Right.
Okay. If you want to answer, I don't know how this happens. What is the treatment of venous ulcer? Is one is compression, one is arterial intervention, total contact cast. I did not talk about ulcer, but total contact cast is for a neuropathic ulcer. Sometimes you get wounds here, and you put a total contact cast. Basically, that's offloading, and you have offloading going on. What is the treatment? I think I'm pretty clear. Compression is the treatment. The pathophysiology of chronic venous insufficiency involves deep venous reflux, superficial venous reflux, deep venous obstruction, or all of the above.
All?
Most common complications of DVT is post-thrombotic syndrome with heaviness, tiredness, fatigue from deep venous reflux and or obstruction, MI, PE, or a stroke.
It's thrombotic syndrome.
When not safe to prescribe compression for venous ulcers, 1 which is normal, 0.9 which is borderline PAD, 0.7 plus which is only mild PAD, or more than, or 0.4, or I should have added less than 0.4 which is severe. So you don't want to do it from 0.5, 0.6 also. I would not do multi-layer compression. Can I use simple compression? You probably could, but you want to do it on a patient who's compliant and well.
So you would say 0.7?
So when not safe to prescribe, 0.4 is not safe.
Okay. So you would be very cautious in anything less than 0.7, but it's not safe in 0.4 or less.
0.4 is definitely not safe.
Okay.
0.7 plus you can do.
Okay.
0.7 plus you can compress. What other factors other than reflux is common in venous disease? Is pulmonary hypertension a factor? Sleep apnea, congestive heart failure,
All of them.
sleeping in a recliner, NSAID use, amlodipine, cardiazem. That's why you see.
I think that's the first thing you do every time I send a patient is you
Yes.
stop the amlodipine.
Amlodipine. So amlodipine, and
Yeah.
you've seen how much better they get just by simply
Yeah.
stopping amlodipine.
I've started doing that a lot because I noticed that you did it, and it really, I mean, it makes a huge difference.
I mean, I had a patient from Nanamatu who had already stopped amlodipine and cardiazem. It's like, well, he's already done everything.
It already did my job.
Yeah. But you guys have learned what I do, and you'll see a lot of problem. What happens is I stopped it, but 6-8 months later somebody puts it back on,
Right.
or I decrease it to 2.5 from 5 or 10 to 5, and then it goes back to 10, and patient goes back to the wound center.
I try to put it on their allergy list if I
mean,
stop it
I don't know if you-
completely.
'cause it's not a true allergy per se.
Intolerance,
Yeah,
I guess.
that's why it's not true allergy. If
Yeah.
they really need it, they get it. In fact, I have a lot of patients that EP does not want to stop their cortisone.
Right.
Yeah.
So
What can you do?
So it is what it is. Then
Yeah.
you live with it. And actually,
Yeah.
a lot of time compression can take care of these problems. Good compression therapy. The problem with compression therapy is compliance.
Yeah.
Moisturizing.
And daily, another I forgot to mention with you with compression. Use daily moisturizing lotion, maybe twice a day. The skin gets really dried with compression stockings. Daily moisturizing lotion, Eucerin, Aquaphor, Cetaphil, and drier the skin. Ask them to use a cream lotion with more cream than moisturizer. As you probably know this, that there's creams that have more cream and less moisturizer, and some are just, and how I know is, if I put cream in my hand and I put it like this, and this just goes off, and one that stays here. One that stays here has more cream. Vaseline by itself works very, very well. Aquaphor, in my view, is just an expensive version of Vaseline.
Eucerin is really good.
Yeah, Eucerin is very good.
Oh, yeah, we slather that on. But some of these people just seem to be allergic to the bathtub.
Yeah.
So you see this wound? What type of wound is this?
Venous.
All right.
The ulcer.
You all passed.
We get to keep our job for another day.
Any questions? I mean, feel free. I didn't cover DVTP because that's a very long topic.
Yeah.
But that's truly not venous insufficiency per se.
So if I'm worried about venous insufficiency or like GSB disease or something like that, would you recommend that I send them to you first or get like venous incompetency tested?
Your choice, personally.
Because I don't know how to interpret any of that. So.
First thing, okay, I should have, I think I talked about it here. So when we do venous insufficiency testing, I'll say reflux from here to here, here to here, or
Yeah.
from proximal calf to mid calf, or just tributaries noted, or reflux noted in tributaries. That means there was no reflux in deep veins, superficial veins. I generally do not do treatment if it's not a reflux in the thigh.
Okay.
Unless until there's a wound. Unless until there's a wound, then I'll try to do maximum I can.
Okay.
But I generally, if you have just calf reflux, I'm probably not going to do anything. I'm going to go hyper on compression basically.
Okay.
Unless until there's large varicosities that I need to take care of. Perforators, I don't go after perforators at all. Perforators mean unless there's a wound. Unless there's a wound, I don't pay a lot of attention to perforators. We check a lot of perforators because we're a good vascular lab, but perforators don't mean anything to me unless I'm dealing with a wound. Because the definition of treating a perforator is very specific when you have a pathological perforator. When it's a certain size and there's reflux in it, and third, it should be really supplying the wound bed. If the perforator is here, somewhere here, and the wound is here, I'm not going to get anything by getting the perforator. And a lot of times, as I say, even if there's a lot of perforators here, when I treat the main vein, perforators are gone because you've treated the main superficial vein.
Sure.
Yeah, I mean, I get a lot of venous insufficiency testing that I'm not really doing anything.
Yeah.
You can get it, you can order it. Either way, I mean, there's a lot of going on in these patients. Sometimes you guys start doing so much that you or others, compression becomes, my whole thing is compression. That's why you'll see a lot of my patients, I actually see them every 6 months. Because if nothing, at least I'm shouting for them for 5-10 minutes.
Yeah.
For compliance with compression, or try to sleep in the bed, or stop their NSAIDs. So if I have a good patient, I have no problem going once a year. But I see some non-compliance, I'll go 6 months.
I've had a lot of success with the lymphedema clinic. They do such a good
So
job.
I didn't talk about it, but I am seeing a lot of phlebolymphodema. A lot of phlebolymphodema. So, and I refer a lot for lymphedema therapy, and I actually have them fitted in lymphedema pumps also a lot. And how do you diagnose lymphedema? You start getting in the calves, there's a kind of hard feel to the leg. It's not that soft, fatty tissue. It's a hard feel to the legs. Then you start getting dorsal hump. Their digits get a little chubby. I have pictures.
There's a couple booklets there.
So here you can see clear lymphedema here.
Oh,
But
yeah.
this is primary lymphedema. Now imagine this patient. Imagine this patient had skin changes here. Then I know that was phlebo lymphedema. But this is primary lymphedema. I know this is primary lymphedema tarda. Tarda means she's probably young in her 30s.
Okay.
But this is clear lymphedema. You have swelling of the leg, you have dorsal hump, and you can see the toes are kind of big,
Yeah.
little chubby toes.
Open
Yeah.
it up, I think it's a better. Does it show anything about the skin?
I have a lot of presentations on lymphedema and all. I thought, this more and more it becomes, but this is lymphedema also.
Oh, yeah.
So, but it's a very good idea to get lymphedema therapy and get lymphedema pump.
Yeah.
Actually, I'll touch base. There's patients who have lymphatic insufficiency or lymphocytography in very early stages of venous disease. I still don't call them lymphedema because they're not clinical lymphedema.
Right.
But the national experts in this field are actually pushing more and more lymphedema pump in early stage, and it makes sense. It just clinically they're nowhere close to lymphedema yet. But do they have lymphocytographically proven lymphatic insufficiency? They probably do, but they're not closer clinically to lymphedema. So anytime I see a venous disease patient who is close to lymphedema in a wound setting, I start getting into lymphedema pumping. Not as much in the clinic, but in the wound center, again, because here I'm treating a bigger thing here.
Right.
I'm not just treating his leg per se, I'm treating recurrence of the wound and all that. So I get, as you can see the theme here, I get aggressive with wounds as compared to just treating a leg.
Sure.
Maybe I should in the leg also so that I prevent a wound. The problem here is all is compliance. The patient population we serve, the practical realities of life, the cost, these things are important to consider. I mean, patients are non-compliant with compression stockings, and I honestly, the companies that sell the pumps, they'll give their numbers at compliance rate of 90%, and I can tell you it's not even 1/3 of that in clinical practice. They're supposed to use pump in each leg every day for an hour. And there are patients who will keep wounds despite that. So I actually go to 1 hour twice a day. Or if they cannot do that, 1.5 hours in each leg a day. And sometimes I go for a higher lymphedema pump, higher degree. Or so with the abdominal component also, because once they put the lymphedema fluid up here, then it stays here. Then it kind of goes, so I put them in lymphedema pump that has the abdominal component also, try to get it up. They really should be doing MLD every day, manual lymphatic drainage. But a lot of lymphedema that I see now is secondary lymphedema.
Right.
These patients are just not in good health to be able to do their MLD. So lymphedema pumps play a good alternative. It's not an alternative, but somebody who's not doing MLD becomes a good alternative. In true lymphedema care, that should not be alternative. They should be doing their MLD every day on top of their lymphedema.